Guillain-Barre is considered an autoimmune disease or an autoimmune process. Its characters we're going to talk about here in a minute, but its pathophysiology or its etiology, the etiology of the syndrome is unknown. Both cellular and humoral immune mechanisms play a role in the immune reaction directed at the nerves. The result is segmental loss of myelin with edema and inflammation of affected nerves. A demyelination occurs. Transmission of nerve impulses is stopped or slowed. So this is something that can happen. It can happen a few days or even weeks after a viral or bacterial infection. You see this a lot in nursing. People have this reaction sometimes to a flu vaccine. It is an acute inflammatory polyneuropathy. It can affect 1 in 100,000 people. It's spontaneous. The recovery can take up to 28 days or longer. What else can I tell you? I think that's all I'm going to have to say on this particular slide. We'll go into more in the next few slides. So back to Guillain-Barre. This is an acute infectious neuronitis of the cranial and peripheral nerves. The immune system overreacts to the infection and it can destroy the myelin sheath. The syndrome usually is preceded by a mild upper respiratory infection or a gastroenteritis. Again, I've seen this at the bedside in relation to flu and pneumonia vaccines. It is ascending in nature. And it's acute, so oftentimes it starts kind of like a numbness, tingling sensation in the toes and feet, and it moves upwards, and it can be rapid in progression. It causes weakness. Also, the main concern here is that it can, in an ascending fashion, can work its way up and actually affect the respiratory muscles, and the patients could require mechanical ventilation. The maximum weakness, usually when the symptom onset starts, and if it gets caught right away, the treatment can start with some steroids and some other medications to help, and the maximum weakness can be reached at 4 weeks. The recovery, though, can take a toll. It can take weeks to years, depending on the severity of the disease. So again, the pathophysiology is, the etiology is unknown. The pathophysiology, we've talked already about a little bit here. It's cellular and humoral immune mechanisms play a role in the immune reaction directed at the nerves. Segmental loss of the myelin happens with edema and inflammation of the affected nerves. So as the demyelination occurs, transmission of nerve impulses are interrupted, stopped, or slowed. And then the recovery phase or the remyelination occurs and neurofunction slowly returns. It starts back from proximal to distal order. So again, the manifestations can be mild to severe. Some of the first symptoms that patient experiences can be pain or paresthesia, that numbness, tingling feeling, and hypotonia, or reduced muscle tone or weakness. So again, that starts ascending. It goes ascending, so it starts at the bottom and works its way up. Paresthesia, pain, hypersensitivity, like patients, like when they're laying in bed and the sheets are laying on them, that can be even to the touch, the pain and sensitivity. Weakness of lower extremities. It has gradual progression of weakness of the upper extremities and facial muscles, possible progression to the respiratory system, including respiratory failure, cardiac dysrhythmias, cerebrospinal fluid that reveals elevated protein levels. I think that's pretty much. And then here, orthostatic hypotension, hypertension, abdominal vagal response, bowel bladder dysfunction, facial flushing, diaphoresis, facial weakness, extraocular eye movement, dysphagia, respiratory failure. And then the diagnostics, basically is primarily we get the patient's history and their symptoms and the assessment that we get from them. So that subjective, objective data really kind of guides through the diagnostic part. Spinal tap can be done to test the cerebral spinal fluid for analysis. If they have an overproduction or over amount of protein in their cerebral spinal fluid, that is an indication that they can have Guillain-Barre. EMG and nerve conduction studies are also used to confirm the diagnosis. Okay, so treatments for this would be plasmapheresis or plasma exchange, or high dose of IVIG or immunoglobulin, are most effective if administered to the patient within the first 2 weeks of the onset of symptoms. They're equally as effective. So plasmapheresis removes antibodies or other immune factors and is used 5 times either daily or every other day for the first 2 weeks. IVIG interferes with the antigen presentation and is given over 5 days. Beyond 4 weeks after the disease onset, plasmapheresis and IVIG therapies have little value, and that's where corticosteroids appear to have little effect in the prognosis or duration of the disease. So the key is the early onset of symptoms, and getting these treatments pretty quickly will help with the treatment and progression of the disease. Some of the nursing care or interventions to consider. The care is directed toward treatment of symptoms, including pain management. Monitor respiratory status closely. Again, the major concern for Guillain-Barre syndrome is difficulty breathing, so monitoring respiratory status closely is very important, and it can happen rapidly, depending on how far the progression, the ascending progression, the respiratory interference can happen rapidly. Provide respiratory treatments. Prepare to initiate respiratory support. So have the emergency equipment available for these patients. Have them on continuous monitoring, pulse ox, cardiac monitoring. Assess for complications of immobility and provide the client and family with support. I think that goes without saying that they're going to need support. Nutritional needs may need to be assisted. Let me see, what else do I have here? Closely monitor the blood pressure and cardiac rate and rhythm during the acute phase, because dysrhythmias can occur. Autonomic dysfunction commonly occurs, so that can be tachycardia or bradycardia, hypertension or hypotension, abnormal sweating, even paralytic ileus. So assessing orthostatic blood pressures, even supporting the blood pressure with vasopressors if necessary. Nutritional needs may be a problem, may have delayed gastric emptying, or they could have a paralytic ileus. A higher potential for aspiration, especially if they lose their gag reflex. So tube feedings would be something to consider for these patients. And then again, because of their mobility or lack of mobility, real aggressive assistance with their ADLs to prevent any breakdown or good range of motion. Get physical therapy involved early to help prevent long-term effects from that muscle weakening. So here's more on the nursing care that I feel like I pretty much already covered in the previous slide. So most patients with Guillain-Barre syndrome will start to recover spontaneously in about 28 days. Although 80% of patients almost completely recover, the process is slow and takes months or years to recover from. About 65% of patients have minor residual signs and symptoms. Older age, rapid onset, or mechanical ventilation are associated with poor prognosis of the disease.